So if you are interested, share the PPT. Share the screen.
Yeah, we are ready.
Good morning, all panelists and attending the Manchu Chara for the webinar. I repeat, because some secretary card this session. Thank you and over to you, sir.
Thank you very much, Arifji. Dear trainees, welcome. So, in continuation with our head and neck series, today we have a talk on the oral tongue by Dr. Dushyant. Because he was preoccupied with some other academic activity, Dr. Aditya, his colleague, is presenting on his behalf, and at the end of it, Aditya would take the question and answer session. Thank you and welcome, Aditya and Dushyant. Over to you both.
Thank you very much, sir, for the opportunity. We met a couple of weeks ago, everyone. So this is a lecture on oral tongue. It's a pre-recorded lecture. So I request you all to pay good attention to it. I'll be answering the questions in the chat. And if there is anything that is that requires more clarity, then we can definitely discuss alongside. So should I start, sir?
Yeah, go ahead, please. Go ahead.
Thank you, sir.
Hello all. Today is the part of National Live Webinar series of National Board of Examination in Medical Sciences. I'm going to talk something about oral cancers, in particularly the tongue cancers. As we all know that head and neck forms the majority of cancers in our region, and even in head and neck, lip and oral cavity cancers is predominant. As you can see from this Globacon 18 data, 60.7% of the head and neck cancer new cases are of lip and oral cavity, and equally are the number of death and 5 years prevalence in head and neck oral, lip and oral cavity cancers. As you can see here, tongue forms the major chunk of all head and neck cancers. This is MSKCC data, forming around 51% of the total patients. In India, if we see region-wise, North, East and South are predominantly affected by tongue cancers, which is evident from the paper by Bose et al. In 2020. Etiology, tobacco is the main killing factor, main etiological factor, followed by alcohol. Tobacco and alcohol together has a multiplying effect. Also, areca nut is culprit. Radiation exposure, poor oral hygiene, immunocompromised state, HPV, genetic factors, and field cancerization are other factors. But here, tobacco is the major form. 49% of etiology is due to tobacco, and others are in different use of tobacco, like smoking or chewing tobacco, and alcohol, as I said, has a multiplying effect.
I'm seeing some.
If you see gender preponderance,
Yes, sir.
Yeah, I'm seeing
slide interesting only.
Yeah, the slides are not being used. I'll just reshare.
Play it again.
Yeah, I'll play it again. Just a minute.
Hello all.
Is it visible now?
As the part of National Live Webinar series,
Sir, it's visual.
National Board of Examination in Medical Sciences, I'm going to talk something about oral cancers, in particularly the tongue cancers. As we all know that head and neck forms the majority of cancers in our region, and even in head and neck, lip and oral cavity cancers is predominant. As you can see from this Globacon 18 data, 60.7% of the head and neck cancer new cases are of lip and oral cavity, and equally are the number of death and 5-year prevalence in head and neck, oral, lip and oral cavity cancers. As you can see here, tongue forms the major chunk of all head and neck cancers. This is MSKCC data, forming around 51% of the total patients. In India, if we see region-wise, North, East and South are predominantly affected by tongue cancers, which is evident from the paper by Bose et al. In 2020. Etiology, tobacco is the main killing factor, main etiological factor, followed by alcohol. Tobacco and alcohol together has a multiplying effect. Also, areca nut is culprit. Radiation exposure, poor oral hygiene, immunocompromised state, HPV, genetic factors, and field cancerization are other factors. But here, tobacco is the major form. 49% of etiology is due to tobacco, and others are in different use of tobacco, like smoking or chewing tobacco, and alcohol, as I said, has a multiplying effect. If you see gender preponderance, 45% of head and neck oral cancers are male, 20% of them are female, and if we see in developed countries and developing countries, the smoking is more in developing countries as a culprit, where here we have chewing tobacco as a major factor. The patient usually present with the history of use of smoking and alcohol, almost in 80 to 90% of them. There is a history of a non-healing ulcer lesion in the tongue. Also associated can be pain, dysphagia, and weight loss if the stage is a bit advanced. If the tongue muscles or the nerves are involved, there will be dysarthria, there will be deviation of the tongue towards one or other side. Odinophagia is also one of the major culprit, especially in the advanced cases when the patient has neglected the disease over a period of time. If the disease has metastasized to the neck, you will be able to find neck nodes also. There can be nerve involvements which can lead to earache, like in lingual, headache, hearing loss, or unilateral nasal blocks in advanced cases. So,
there is no audio in right now.
Sorry?
There is no audio right now.
Now you have to keep in mind.
You're not able to hear the audio? Hello?
Yes, sir.
Yeah. So, did the audio stop just now recently, or has it not been?
Just recently.
About certain things.
Now?
Very huge tumor might not
Yes, sir. It's fine now.
do bimanual or finger palpation. Also, you have to keep in mind that this can be painful ulcers, and patient may not allow you to palpate or may hold the tongue rigid, which can falsely upstage the tumor. Also, the peritumoral edema can give false impression about the actual dimension of the tumor. So this clinical classification or this palpable method of identifying and classifying needs to be taken with a pinch of salt. If we see AJCC 8 classification now, what has changed from the AJCC 7 is after the tumor's dimension, that is less than equal to 2, 2 to 4, more than 4 and others, they have added depth of invasion, that is DOI, also as one more dimension which will classify the tumors or upstage them accordingly. So this needs to be taken care while you are going to classify the term T stage in AJCC 8 classification. If you compare AJCC 7th edition and AJCC 8th edition, you can see here that T0 is now deleted. The T1 in AJCC 7th is less than equal to 2 centimeter, which is here less than equal to 2 centimeters, and depth of invasion less than or equal to 5 millimeter. The T2 in 7th was size 2 to 4 centimeter. Here the T2 is less than 2 centimeter and the DOI 5 to 10 millimeter, or a 2 to 4 centimeter tumor which has depth less than 10 millimeter. As you can see, the tumor which is less than 2 centimeter, which was T1 previously, but now if it has a more depth of invasion, which is 5 to 10 millimeter, is upstaged to T2. If you can see T3, the size was more than 4 centimeter previously. Now the T3 has size more than 4 centimeters, or any tumor of any size with depth of invasion more than 10 millimeters. T4A, which was moderately advanced in AJCC 7, is now removed from AJCC 8 as the depth of invasion takes care of the muscle involvement. The T4B stays. Let us brush through important surgical anatomy of tongue. Tongue forms an important part of oral cavity anatomically and functionally. It is in close proximity to the pharynx and larynx posteriorly. It is easily accessible for inspection and palpation. Tongue can be grossly divided into anterior 2/3 and posterior 1/3, that is the anterior body of the tongue, and posterior 1/3, that is base tongue or the root of the tongue. For the discussion of this section, we will limit ourselves to the anterior tongue. As you can see, the tongue is a paired organ having bilaterally symmetrical musculature and innervation, and in the midline it is separated from median sulcus or septum, and it kind of works like a pair organ. The tongue is an important sensory organ. It has special and general sensations which are very important to us. As you can see in this picture, there is posteriorly base of tongue. You can see the circumambulate papillae which are separating the anterior tongue from the base tongue. In the body of the tongue, you can see anteriorly in the sides fungiform papillae. To inspect the anterior tongue or the anterior floor of mouth is very important. You can see many subparts of the tongue here in the sublingual fold of the sublingual gland. You can see the lingual caruncle in the midline and sublingual sulcus bilaterally. You can palpate and feel the mandibular torus on bilaterally and sublingual folds bilaterally. You can also appreciate sublingual veins bilaterally in the floor mouth going towards the tongue. Tongue is a mobile organ and its movements are very important in speech and deglutition. There are intrinsic muscles of the tongue and extrinsic muscles of the tongue. Genioglossus, hyoglossus, styloglossus, and palatoglossus. These muscles originates from the different portions and are inserted inside the tongue. The three muscles are supplied by hypoglossal nerve, and palatoglossus is supplied by vagus nerve and pharyngeal plexus. Different actions of these muscles causes different movement of the tongue. This is cross-sectional view of tongue at second molar. You can see various fibers of intrinsic muscle of the tongue, which is encapsulating the extrinsic muscles of the tongue. They have superior, inferior, longitudinal muscle fibers as well as transverse and vertical muscle fibers crisscrossing each other. Certain facial layers and muscles forms the compartments also in the tongue, which has importance in the tumor involvement as well as planning your surgery. The supply to the tongue is from the lingual artery, which often becomes common with the facial artery and forming a linguofacial trunk. The lingual artery originates near the posterior extent of the greater cornu of the hyoid bone, passes deep to the hypoglossal nerve, and then between the middle pharyngeal constrictor and hyoglossus, the artery enters the deep surface of the tongue and extends as far anteriorly as its apex. The lingual artery has four named branches: suprahyoid, dorsal lingual, sublingual, and deep lingual arteries, which almost acts like end arteries. Here again, in the coronal sections taken at the second molar tooth, you can see here that hyoglossus muscle and mylohyoid muscle form kind of compartments. You can see that lingual artery is medial to hyoglossus muscle, and hypoglossal nerve is in between your hyoglossus muscle and mylohyoid muscle. It is important to understand this relation to the muscles, which not only gives you signs of involvement during the imaging, but also helps you to finalize your resection, especially when you are concerned about the pattern of spread and you want to do a compartment kind of resection. Like all other organs, the venous drainage follows the arterial pattern, and the deep lingual vein and the sublingual veins, they ultimately drains into the facial vein, retromandibular vein, to ultimately drain into IJV. Developmentally, tongue is formed from the oval four arches. You can see the ventral portion of the pharyngeal arches seen from the above, showing the development of the tongue. In picture A, you can see it at the 5 weeks. In B, you can see at the 5 months. And in picture C, you can see the definitive tongue formed by the different parts of the all four pharyngeal arches. Here you can see the trigeminal nerve and its mandibular division. Carefully observe the coda tympani from the facial nerve, which is joining the lingual nerve. You can see the glossopharyngeal nerve here, supplying the posterior part of the tongue. Also observe the communication with the vagus nerve and the contribution of both to the pharyngeal plexus. Here you can see the hypoglossal nerve, which is in its course supplying the motor muscles of the tongue. Imaging forms the cornerstone for the pre-treatment evaluation of tongue. It also helps us to decide the further management according to the staging and involvement of the organ. I will urge you all to read this paper by Sukrita Arya on imaging in oral cancers. Imaging helps us to answer certain very important questions, like what is the true disease extent, what is the clinical TNM staging, and there are certain information beyond the TNM also. It also helps you to plan the therapy. Will the patient require single modality or multimodality, which in turn helps you to counsel patient. It also gives you idea about the resectability of the disease, of the primary as well as the node, and helps you to plan your surgery. So when you are talking about the tongue, you are usually talking about the area in this red box. As you can see, in the middle is the tongue, and in the sides and in the base is the floor mouth. It also abuts the alveolus, and superiorly it forms the hard palate. But as you can see, most of the part of the box is of the soft tissue. So obviously, the contrast enhanced MRI is usually the first choice of your investigation to know the disease. It has a superior soft tissue characterization, and less than 10% of the bone erosion happens when the tongue tumor goes to the floor mouth, which can be seen by plain CT bone windows with contrast enhanced MRI. As you can see in this slide, on the left side is your CT scan, and in the right side is your contrast enhanced MRI. You can very well see the delineation of disease, which is much better on the right side of your slide. As we previously talked about, AJCC 8 has involved the depth of invasion also in the classification of the disease, and it has something to do with your imaging also. At this point, let us find out that how the depth of invasion measurement changes in a tumor which is exophytic versus which is invasive. As you can see in the top of the picture, there is an exophytic tumor. Now you draw a line from the basement membrane, which is normal, and the invasion or the line which is going below is your depth of invasion. If you can see that from the basement membrane, the top of the tumor, which is exophytic, from the bottom where the basement is your tumor thickness. Where in the inferior, there is a crater-like depression because of the invasion. There the basement membrane is at the top, which is normal. The basement membrane has deepened due to the depth of invasion, but the tumor thickness, which is the top of the tumor and the basement membrane, is less. So as you can see that exophytic tumors has less depth of invasion than tumor thickness, while invasive tumors have more depth of invasion than tumor thickness. Now, to replicate same principle of tumor thickness versus depth of invasion is a bit difficult while doing your MRI. Not only you are not able to find exact basement membrane, which you will be in your histopathology, there will be other structures or other factors like peritumoral edema or infection. But a telltale sign is that you draw a line, a reference line at the mucosal level of the tumor, and whatever is deeper to the line, you can say it's a depth of invasion, and whatever is the superficial to the line, you can interpret as a exophytic component or part of tumor thickness. Remember that usually in MRI there is an overestimation about the dimension of the tumor. So in most of the series it is found that the DOI or the tumor thickness or the dimensions of the tumor were less in the histopathology when compared to your MRI. Here you can see in the contrast enhanced MRI of the CA of the right side of the tongue. You can see that on the left side of the image, the tumor doesn't go to the midline. It is fairly small. The depth is very less. Whereas on the right side of the image, you can see the tumor almost pushing the midline. This tumor has an important factor that how you are going to plan your surgery. In this image, not only the tumor is going through and through across the midline, it is involving bilateral nodes also. The extent of tumor visible on MRI can guide you about planning your surgery as well as the resectability and non-resectability. In the left side of the image, you can see that tumor is involving unilateral neurovascular bundle, where on the right side you can see that tumor has not only crossed the midline, but it is involving bilateral neurovascular bundle. The imaging also gives you idea about if the tumor is going to the nearby structures. In the A, you can see that the tumor has gone to the vallecula and pre-epiglottic space also. In B, the tumor has gone to the tonsillar area. This can be the relative contraindication to do the surgery, and it also explains that there will be certain morbidity involved in the surgical treatment. This sagittal contrast enhanced MRI shows an enhancing tongue lesion which is reaching to floor mouth, base tongue and vallecula. That is also invading the mandible anteriorly. This is a very aggressive disease. The bulky tumors usually limit our access and inspection. Here, the MRI can be of help. In A, you can see the bulky tumor is abutting the lingual cortex of mandible, but it is not involving or eroding it. While in the B, you can see there is an erosion of the mandible with the tumor with marrow enhancement and an extension towards lip also. So according to the spread of the tumor, you can find and plan your therapy. If there is a spread of tumor across the midline, you have to plan the therapy to address the bilateral neck nodes. The inferior spread of the tumor to growth neurovascular bundles may need a total glossectomy. The posterior spread towards tonsil, vallecula, pre-epiglottic space, or hyoid is a relative surgical contraindication, and you may think of chemoradiation. A far posterior spread in the masticatory space can term it's a very advanced and palliative case. A little spread towards the bone with the erosion can need a lateral mandibulectomy. A perineural spread along the lingual nerve or to mandibular nerve is an adverse prognostic sign, and you may think of giving a palliative care. I will briefly touch over the neck node metastasis, as there will be a dedicated session in the subsequent talks which will be taken by an expert on the neck node metastasis. As you can see from the numbers, tongue is notorious for neck node metastasis. In a clinically N0 neck, the chances of having level 1, 2, and 3 neck node metastasis are 14, 19, and 16%, and there can be a 3% level 4 metastasis, where in the N plus neck, it's a more than 20% chances of involvement of level 1, 2, 3, and 4. If we consider the risk factors for the nodal metastasis in patients with oral cancer, tongue itself is an high-risk disease. The advanced T stage of T3 or T4, depth of invasion more than 8 mm, poor histopathological grade, infiltrative tumors, lymphatic permeation, vascular invasion, perineural invasion, and invading front of the tumor are certain high-risk criteria. In a paper from Nitin Shah from 2009, you can see the different risk biology and aggressiveness of the tumor according to the depth of invasion. As you can see, the depth of invasion increasing from 2 to 3 to 8 to more than 8 mm, the risk of focal metastasis, overall incidence of nodal metastasis, and patients dead from disease increases drastically. The goal of your treatment is cure of the cancer, but at the same time, tongue being an functional organ, you would like to preserve and restore the speech, mastication, swallowing, and external appearance of the organ. You will also like to minimize the sequelae of treatment, such as dental decay, posterior radionecrosis of the mandible, and the trismus. The selection options you have to select with awareness that there can be subsequent new primaries and you will need to manage those tumors also. As in all cancers, here also you need to identify and give equal weightage to the tumor factors, to the patient factors, and to the setup or physician factors before deciding the line of treatment. Surgery remains the mainstay and cornerstone of treatment, but here you can see in the paper by Brian O'Sullivan in Oral Cancer in 2013, the external beam radiation therapy can be thought in early disease when the patient is intolerant to the surgery. In early diseases, when the anticipated cosmetic consequences of surgery, like in lip, are drastic, then you can think of EBRT. Unresectable diseases, in that it's usually combined with chemotherapy, and in advanced diseases, where the patients are intolerant to the surgery or poor performance status, it can be used in primary settings. The chemotherapy can be used in advanced diseases or unresectable diseases in combination with radiotherapy. In early and superficially well-differentiated tumors, which are located more than 5 mm from the mandible, interstitial brachytherapy can be thought of. In a paper by Shah JP in 2009 in Oncology, it is stated that survival with the single modality treatment is best with surgery when it is compared with radiation in all 1 to 4 stage of the tumor. Also, the choice of treatment depends upon the site, location, stage, histology, and nodal status of the disease, and also what are the complications, compliances, conveniences, cost, and competence in treatment involved. Glossectomy is the one box, which is the term chosen for any surgery of the tongue. Can be partial, can be hemi, can be subtotal, can be transoral, can be total, and n number of the names. Due to these different names of the glossectomies, it becomes impossible to compare the glossectomy, the techniques, and the result across different surgeons and across different institutes. So, recently, a classification of glossectomy was proposed by this group, which is from European Institute of Oncology, MSKCC, University of Oklahoma, and Esicar Magno Center from the Brazil. They try to devise a nomenclature of glossectomies according to the different parts involved in the surgery. The type 1 glossectomy or mucosectomy involves mucosa and submucosa only. The resection is limited up to the intrinsic muscle fibers, so that is the partial resection of the intrinsic fibers. You are not going deep up to the extrinsic muscle fibers. Precancerous lesions or superficial suspicious lesions which are limited to epithelium, they can be dealt with this type of mucosectomy. Type 2 or partial glossectomy involves mucosa and submucosa and full thickness of intrinsic muscle resection going top to the extrinsic muscles, but the muscles are not sacrificed. The lesion infiltrating submucosa and superficially into the intrinsic muscles but not to the extrinsic muscles, or the infiltration is less than 10 millimeter deep, are amenable to this type of glossectomies. Type 3A or hemiglossectomies involve mucosa, submucosa, and intrinsic as well as extrinsic muscles of the ipsilateral side. The base of tongue is preserved and often the tip of tongue is also preserved. The lesions which are infiltrating the intrinsic and minimally to the extrinsic muscle of the tongue, where the infiltration is greater than 10 millimeter but confined within the same side, are amenable to this glossectomies. Type 3B or compartmental hemiglossectomy involves mucosa, submucosa, intrinsic and extrinsic muscles of ipsilateral side of the lesion, genioglossus, hyoglossus, styloglossus muscles, and the inferior portion of the palatoglossus. Medially, the midline raphe is intruded. The lingual nerve is resected as far cranially as possible. The hypoglossal nerve is removed after the ANSA. The lingual artery and veins are ligated in the proximity to the hyoid bone, and lesion massively infiltrating the intrinsic and extrinsic muscles but confined on the ipsilateral side needs this type of glossectomies. Type 4A is subtotal glossectomy, which is equal to that hemiglossectomy kind of infiltration, but here it is bilaterally. When the tumor also involves one side of the base tongue and one side of base tongue is not involved, you need type 4B glossectomies. Entire mobile tongue and base tongue, when it is involved, it needs a massive resection, which amounts to total glossectomy or type 5. Glossectomy type X is reserved when the adjacent structures such as geniohyoid, digastric, epiglottis, larynx, lateral wall of pharynx, or mandible are involved or not involved in the extended glossectomy. The surgery of the tongue tumors can be approached through various accesses. When the oral cavity has no submucous fibrosis and the tongue can be protruded nicely, then the transoral approach can be used. In certain cases, with the limited mouth opening, you may need a mandibulotomy or a skin flap, like a hemiskin flap, a visor flap, or an upper cheek flap. This is a tumor which is a junctional tumor, which is going to the anterior as well as the posterior third of the tongue. A mandibulotomy approach is used here. A paramedian mandibulotomy is done. As you can see here, the paramedian mandibulotomy is done between the lateral incisor and canine. This is the safe area to do the mandibulotomy, as the exit of the ventral nerve is preserved, which will preserve the sensations over the chin, Also, this area doesn't have much forces of mastication, and 2 good mini plate fixation is enough. This area can also be excluded from the radiation field, causing less postoperative complications in the bone if the radiation is required for the tongue cancer. If the tumor is going from the tongue to the floor mouth and encroaching over the alveolus or doing the erosion, according to the bone involvement, you may need a lingual cortex marginal mandibulectomy or a segmental mandibulectomy for the resection. I will also like to touch upon this principle of compartmental surgery in tongue tumors by Calabrese et al. The thought process is to remove the lesion as well as the pathway of the progression of the tumor, that are the muscular, lymphatic, and vascular structures in the territory. You need to remove the at-risk metastatic structures also while you are removing the primary tumor, and then do the rational reconstruction. As you can see in these sectional studies as well as MRI, the tumor cells can migrate longitudinally following the path of least resistance from the primary side along and in between the intrinsic and extrinsic muscle fibers in the pattern of spread, which varies according to the orientation of the infiltrated muscle. Tumor invasion of nerves and vessels also progresses along the same path, which is parallel to muscle fibers. The sublingual areolar tissue and the sublingual gland, with the modification of the surrounding tissue stroma, represents the potential path of the spread. And you can see that as the muscles are cut, even if partially, they lose the function. So in this slide on the left side, you see the conventional section with 1 centimeter or more margins all around, which in the index case can involve the opposite side of the tongue musculature also. While in the right side, you can see that compartment doesn't cross the midline. So the paradigm shift from the circumferential to the longitudinal resection paradoxically appears to be initially more destructive, but the result in a rational and functionally conservative devolution, which avoids unnecessary violation of the contralateral hemitongue compartment, which in turn improves the reconstructive, functional, and oncological outcomes. Luca Calabrese and group have also studied the long-term oncological results of compartmental tongue surgery, which are interesting to look at. In the study of 193 oral tongues, 50 received standard surgery with more than a centimeter margin circumference all around, and 143 received compartment surgery. And after 5 years, the local disease control was achieved in 88.4% of compartment patients, which was 16.8% improvement on the standard surgery. The local regional disease control was in compartment 83.5%, which was 24.4% improvement than conventional surgery, and OS of 70.7% with 27.3% improvement over the conventional surgical techniques. Now let us talk something about the margins in glossectomy. So whenever you are resecting a tongue cancer, you need to identify the margins of the resection, and you need to orient your pathologist with the specimen either on-site or with color coding or some other method so they can accurately report your resection. When we see in literature this magic figure of 0.5 millimeter margin, let us see that this concept came from the paper by Elliot Strong, Jatin Shah in 1978, where the recurrence rate in this group of the patients of 62 were compared with the patient who had negative margins, and the positive margin meant that margin which is close or less than 5 centimeter from the tumor and other histopathological aspects. The margins were revisited by same group again recently, and a new figure of 2.2 mm was proposed. It was a squamous cell carcinoma of oral tongue, and it was a retrospective study in a multivariate model adjusting for the pathological factors, positive margins, and margins of 0.01 to 2.2 millimeter were the variables which were most significantly associated with a recurrence. In a study by Moran Amit et al., it was proposed that specimen-derived margins assessment led to significant improvement in the rate of negative margins rather than patient-derived margins. This was in 71 patients randomized control trial. So obviously, the margin status was a powerful indicator and is a powerful indicator for locoregional failure. Here you can see from 31% to 55%. And that will require different modality and different intensity of the treatment, and they will have different disease-free and overall survival patterns. Obviously, the T stage will have great impact on the overall survival and disease-specific survival from T1 to T4, dropping down from 81% to 39% OS and 93% to 54% in disease-specific survival. Similar is true about the nodal status also, with worse OS and DFS as the nodal stage is increasing. If we see this SPEAR database about the 5-year relative survival in the oral cancer patients, the tongue is an aggressive disease. Stage by stage, we have poor 5-year relative survival in tongue patients when compared to lip cancers or gum or mouth cancers. We also have Indian clinical practice consensus guidelines for the management of oral cavity cancer by our experts in the group, and I will urge you all to read them. Thank you.
Thank you, Aditya and Dushyant. That was very good talk. Fantastic. If there are any questions, Aditya will take on behalf of Dushyant and answer all of them.
So if I were to sum up the whole scenario, especially for our wonderful PGs and residents, The most important thing that tongue still continues to teach us is that clinical examination is of paramount importance. As you have seen that there is a lot of submucosal disease in tongues where it may not be visible on just inspection. Palpation is mandatory. Anatomic clear dimensions, clear diversifications, and clear bifurcations are very important. So that is where it starts. It cannot be stressed enough that tongue is the classical example of knowing your anatomy well to do the surgery well. Of course, every organ requires that, but tongue, particularly with its varied lymphatic supply, vascular supply, its relation to the structures around which are not related directly to the tongue, and the classical three-dimensional removal, as we said, in the compartmental glossectomy or in others, that remains the cornerstone of treatment of CA tongue. If the first attempt is not made well, there are chances that it may cause a problem. Yes. So there is a question in the chat. With respect to the periosteum or other barrier structures, is there a difference in the margin? Okay. So basically it is broadly considered without any data evidence that periosteum itself constitutes about 5 millimeters of margin. This is especially true when you are not able to gain clear 1 centimeter margins that you desire at all points, and the tumor is not infiltrating the bony side, the GB sulcus side of the story. So if it's a floor of the mouth disease where the alveolus is not involved, then we can safely strip the periosteum off and we can consider that to be a clear enough margin because of the thickness and the sanctity of the barrier that is there. If the periosteum is breached, then we have no option but to take a segment of the bone if we are not skilled enough, or and easier if we have access to good saws and everything, and inner cortical marginal mandibulectomy is also the way to go, but it requires a lot of precision because even a slightly thicker segment may lead to devascularization because the endosteal vessels remain very, very close to the structures that are there. So periosteum can be considered a margin if it has not been breached, and if the disease, even though in the floor of mouth, remains confined to the lingual side and not the GBS side. Sir, if a disease is 4 millimeters short of midline, as we are going to cross the midline while doing resection, should we do a bilateral neck dissection? Yeah, so it's a judgment call. Of course, your scans will determine whether your neck nodes are positive or not. The thing to consider here is that if the disease is just 4 millimeters short of midline, tongue is generally considered to be a bad disease in a colloquial sense. Again, there is not great data to support what we say, but the tongue is generally considered a worse off disease than, say, an alveolar disease. So whenever we are dealing with tongue, it is likely that we are going to radiate the contralateral side of the neck also. So if we are reasonably confident that there is no nodal burden in the contralateral neck, you can avoid doing that because if it's 4 millimeters, it is not technically crossed and you are in any way going to give adjuvant radiation to the patient. So what you may do is ask your radiation oncologist to be in the loop and give good radiation to the contralateral neck if you want to avoid doing lateral neck dissection, because it is likely that even after doing your lateral neck dissection and it being an N0 with the disease that is tongue, the radiation oncologist might be tempted to cover the neck on the contralateral side. So I think, sir, those are the questions.
Yeah, all the questions. Yeah, thank you very much. And we would also have Dr. Kaustubhai's lecture on the margins in the coming time.
Yes.
So
yes,
all the other issues will be sorted. Thank you very much, Aditya, chipping in and saving our day. And thanks to Dushyant and Kaustubhai.
Thank you very much.
Thank you. And over to you, Arifji. Thank you.
Thank you all panelists attending for joining the program.
Thank you. Bye-bye.